Okay, Jyoti.
Good evening. Good evening. This is Dr. Azmi Saundarya. I'm the clinical lead and consultant radiation oncologist at Gleneagles Hospital, Fortis Network, Chennai. So today we'll be talking about radiation therapy. So what is radiation therapy and how does it work? And why do we use radiation therapy? So initially, let's start with the definition. So, what is radiation therapy? Radiation therapy is basically we here use high energy waves. It can be X-rays or it can be gamma rays, with which help we use to destroy the cancer cells. So, radiation therapy is used for all types of cancers, namely breast cancer, lung cancer, head and neck cancer, brain, CNS tumors, pancreas, prostate cancers. So, initially, when the radiation therapy is absorbed by so once we plan radiation therapy for a patient, so there are two types of way we can deliver radiation therapy. It is called as external beam radiotherapy or brachytherapy, which is internal radiation. So, about the external beam radiation therapy, so here we use a machine which we call it as a LINAC, a linear accelerator, which help we use beams from the external. That is why it is called as external beam radiotherapy. And the machine actually rotates around the patient and it targets. So it is a local treatment. Again, we have to understand that once radiation therapy is planned, it is a local treatment. So, for example, if I'm planning radiation therapy for breast, only the breast will receive radiation therapy, and the critical structures next to the organ. For example, it can be the heart, it can be the lung. So we have dose limits for such organs, and the rest of the body doesn't receive radiation therapy. So if a patient has received radiation therapy to the breast and maybe later after few years requires radiation again to a different area in the body, it is still possible. So now let's look at the way it radiation therapy acts, mechanism of action of radiation therapy. So radiation therapy, once we plan for a patient, we actually plan the volume where it should be delivered. So once the radiation therapy is absorbed by the body, by that particular organ, what happens in the cell? The cell absorbs radiation therapy, and the water molecule in the cell is ionized by radiation therapy, and now it releases the free radicals. So these free radicals can actually damage the DNA. So there are two ways of radiation therapy that can affect the DNA. It can be a direct attack or an indirect damage. So radiation therapy can be of many types. We use X-rays, we use gamma rays. There are very specific X-rays called high energy X-rays called very focused high energy X-rays. When you use, you call it as stereotactic body radiotherapy, which is a very focused radiation therapy. Now, once patient receives radiation therapy, does it kill the cancer cells right away? No, it doesn't. It takes time. It takes days to weeks. So the cancer killing begins once the full dose of radiation therapy is delivered, and then the patient will be kept on follow. So certain kinds of tumor, only radiation therapy can be given, and in certain kinds of tumor, you will need a multidisciplinary team approach where you need the help of medical oncologist, surgical oncologist to plan what is needed for the patient. Because at times we give radiation therapy along with chemotherapy. Then we call it as concurrent chemoradiotherapy. And sometimes radiation is done after surgery. And few scenarios, radiation therapy is also done prior to surgery. So why is it done prior to surgery? Here we call it as we term it as neoadjuvant radiotherapy. Neoadjuvant. Sometimes it is also given with chemotherapy, so you call it as neoadjuvant chemoradiotherapy, neoadjuvant therapy as such. This is done to shrink the tumor, so you're actually helping the surgeon to have a complete. It makes the surgery easy for them to completely resect the tumor. And once the radiation is done, the patient will always be kept on follow up. So we looked at the way radiation is given in certain situations where you call it as definitive chemoradiotherapy. This is done in places like head and neck regions. Sometimes cancer in the head and neck may be inoperable, or sometimes the patient may not be fit for surgery. In such therapy, and we have good results with which is equivalent to surgery. And now moving on to how we actually diagnose, and then what do we do for the patient. So first, after a consultation, we have a multidisciplinary team approach. We have a tumor board, so where we decide what is best for the patient, and then we convey it to the patient. So we also tell them the treatment goals and also side effects of each treatment, because radiation therapy does have side effects. It depends on the organ the radiation therapy is received. So now, again, radiation therapy, what type of radiation therapy we are going to use, and how many days of radiation therapy, and so how many fractions, because radiation therapy is given as a fractionated form. So it will be every day we give, and we give it from Monday to Friday. So this will be for 5 days a week. Sometimes we have short courses of radiation therapy where we finish the treatment within 5 days. There are two ways of giving radiation. In, for example, if it is breast cancer, there are ways where we can give radiation therapy for 5 weeks of treatment, and we have moved on to the 3 weeks of treatment in breast cancer, and now we are looking at just 1 week of radiation therapy. So this is how the number of days is planned. It is planned according to the type of disease, the site where the disease is present, where the site is, and which stage the patient has presented. All these factors are considered before deciding the number of days the patient will need radiation therapy. And again, let's move on to the external beam radiation therapy, and the other type is the internal radiation. So, what is internal radiation? This is something very few people know about. This is called as brachytherapy, but it's a very important type of treatment modality for cancers, especially cervical cancer, sarcomas, or even breast cancer. So, for such organs, brachytherapy plays a very important role, because what we do here is just opposite of what we do in external beam radiotherapy. So like I mentioned, in external beam radiotherapy, we actually, it is the x-rays that comes from the machine, and the machine moves around the patient, and the patient lies still on the couch. But here what happens is, the patient it sometimes it can be an OT procedure. Brachytherapy can be an OT procedure. We try to place the radioactive source near the cancer. So it is a very the brachytherapy source, sometimes it is in a seed form or a ribbon form, and it is mostly capsulated. And this is actually through a wire. It passes through the wire, and it reaches the place where the cancer is. So this procedure is used sometimes an OT procedure. And internal radiation actually done after external beam radiation therapy for cervical cancer gives excellent reports, because because the biggest advantage what you see with brachytherapy is the dose that falls will be only in the region of cancer. So you have a sharp dose fall, and hence the critical structure that is adjacent to the organ that is affected will not receive dose, and so the side effects are minimum, and the concentrated dose falls on the organ that has the disease. So with brachytherapy, we see very good results, especially in cervical cancer. And now moving on to the side effects of radiation therapy. Yes, radiation therapy has side effects. It depends on the site. For example, if I'm treating the patient with radiation therapy for a CNS tumors, that is brain tumors in the brain. Usually, the patient comes to the OP after surgery, and then we wait for 3 weeks before starting radiation therapy. This is done because we need to give them time for healing. The surgical wound has to heal, so we give them the time, and then once the radiation is planned, what we do is we do a CT scan. This we call it as planning CT scan. So it is CT simulation that is done. After the planning CT scan, we plan. We use the MRI. If it is brain, we are going to use the MRI brain, and we fuse it with the planning CT scan, and then we target. We draw the volumes where the dose has to be delivered, and once the computer planning is done, we use higher end techniques. The commonly used term is intensity modulated radiation therapy, and something we call it as a rapid arc. The other term is in image guided radiation therapy. So higher end, so these are all the higher end techniques that we use here in Gleneagles Hospital. So with the IMRT or IGRT, what we do is we have a computer-based planning, and then we evaluate the plan. We also the important part of planning is also looking at the organs which are very nearby the target. So we look at the dose that is received by the organ, and once we are satisfied with the plan, we approve it, and then we start executing the treatment from day one. So this will go on, for example, if the number of days that is planned is 25 days, so Monday through Friday the patient will receive radiation therapy, and then next week Monday to Friday. So this is a pattern, and this will be for about 5 weeks of treatment. So this is this patient normally, for example, if it is CNS tumors, like I mentioned, if it is CNS tumors, the patient after few weeks of treatment, in general, radiation therapy can cause fatigue and extreme tiredness. The patient can tell us that the patient is feeling weak. This we normally see after the third. So, tiredness, how do we address the tiredness here? It is just rest and hydration and a good calorie and high protein diet. There has to be an adequate a calorie intake, which is very important because the body also needs to recover from the radiation therapy, because a normal healthy tissue needs to recover from the radiation therapy. So now what happens? The third week, the patient complains of tiredness. Sometimes, if it is the tumor in the brain, the patient can also complain of headaches, headaches, or even vomiting sensation. But this is all transient, and it gets better with time. After a few days of completion of radiation therapy, the patient starts getting better. For example, if the patient is going to get radiation therapy for head and neck cancers, head and neck cancer, the patient it will be started on treatment, and sometimes, most often, the treatment will also need systemic treatment, that we call it as chemotherapy or target therapy or immunotherapy. So these treatments are given along with radiation therapy. So what happens is that once a patient is started on radiation therapy, the we prescribe them what all to be done to support the treatment. So on day one, the patient is given the medicines that is required to be taken along with the radiation therapy. So usually what happens is week 3, in head and neck patients, the patient will have throat pain, or sometimes they can feel extreme tiredness. Most often it will be the difficulty in chewing and difficulty in swallowing, and they will find it difficult to even swallow the saliva. So what happens is sometimes the saliva starts pooling, and we normally tell them to actually spit the saliva, because it will be very hard for the patients on radiation therapy to swallow the saliva. So, but this is going to be transient, because once a patient completes radiation therapy, 1 month from the day of completing the radiation therapy, the patient actually becomes better. All these symptoms, like I mentioned, the swallowing difficulties, or it gets better over time. And a few times, what happens is if the patient is not able to take anything through mouth, then we recommend them take tube, rice tube feeding. We call it as, we get the help of the dietitian also. And with the dietitian, we actually come up with a very good diet plan, so that the patient doesn't, because in a head and neck treatment, on head and neck treatment, the patient tend to lose weight. They, because of radiation therapy, the side effect of radiation therapy, the patient tend to lose the taste sensation also. So they will have loss of appetite, they will not eat, and the saliva becomes thick. So how do we cope up with such side effects? Normally what we recommend is we prescribe them syrups that can soothe the lining in the, for them to swallow. So what else can be done? We also try ice chips. We I ask them to take the crushed ice chips. So when it is placed, it sometimes helps in the stimulating the saliva, in saliva stimulation. So normally what happens is, with radiation therapy, though we use higher end techniques, the saliva production becomes less. The saliva production becomes less. However, this type of side effect has actually improved with the techniques that we use now compared to what it was earlier. Those days, we used to see a lot of side effects, but now we are moving towards modern techniques like IMRT or IGRT, or we did rapid arc. Sometimes that's also called as volumetric modulated arc therapy. With this, we actually, the side effect that we see is less. But however, head and neck cancers, because it is a complex, because the complex structures are present there, patients tend to have minimal side effects. Now, the saliva production becomes less after head and neck radiation therapy, and this getting better takes few months. And also the taste sensation, which is very important to remember, that taste sensation is lost by the patient, so they don't feel hungry, and they don't like the food also, because they have lost the taste sensation. Sometimes they feel they have the metallic taste. Now, this taste sensation, if you ask me, does it come back? Yes, it does. It comes back, but it takes time. So, the spicy food, they will not be able to take spicy food even after few months. But every taste sensation comes back within a few weeks. Be it bitter taste, salt, sweet, everything comes back. But the spice, even after 6 months, the patient comes back to, and tells us that they are not able to take spicy food. So they are sometimes on bland diet, less spicy food. And coming to the rehab, which is very, very important post therapy, radiation therapy, we get the help of a speech and swallowing therapist, a dietitian, and also a psycho-oncologist. So it is going to be a team approach when it is head and neck cancers. And also dental hygiene is very important prior to starting radiation therapy for head and neck cancers. because dental procedures, major dental procedures, we don't recommend after radiotherapy for at least 1 to 2 years. We don't recommend unless it is an emergency. Even in that scenario, a well-trained dentist who has a very good oncology background and knowledge, a support system, I think they would be able to guide the patients if they have dental issues post radiation therapy. Now, moving on to the other structures, like let's say if we are going to treat gastrointestinal structures like stomach or the colon. Um, so what happens is here the patient will have side effects which are nausea, vomiting, not always, and sometimes they tolerate really well. But tiredness is something that we will see in most of the patients receiving radiation therapy to the gut. Now, how do we overcome this? When the patient tells us that they have nausea and vomiting, we actually prescribe them antiemetics, which actually helps, and also proton pump inhibitors. These are the medicines that will actually help settle the symptoms, and they are able to finish the treatment. So now moving on to the sarcoma treatment. Sarcoma treatment, mostly there are two types of radiotherapy method that can be used when we are treating sarcomas. For example, if it is going to be we call it as pre-operative radiotherapy. This is also done, and in few centers we follow, and few cases we also follow post-operative radiotherapy in sarcomas. So sarcoma is a place again where brachytherapy is also used. Sarcomas are generally seen in limbs. So, if, for example, if it is going to be thigh region and you're going to give radiation therapy, we actually tell the patient that you have to keep the area clean. It has to be dry because along the groin region, sometimes if it is in the thigh, it becomes wet, and what happens is the radiation reaction also increases in that scenario when once the radiation starts. So patients are given. We give them the radiation, the supportive medications like aloe vera creams. So this is done every day basis. They have to apply post radiation therapy in the night. They can apply. So once a patient completes the treatment, the next step will be to be on follow up. It also depends on the type of disease, the site where the disease. For example, if it is going to be brain, we tell them to come back after 3 months, and we do an MRI scan. So, if the patient has a symptom before that, then he or she may need an imaging before the 3 months period. Generally, we tell them 3 months. Every 3 months, we follow them, and this will be for like 2 years. And after 2 years, 2 to 5 years, we tell them every 6 months. So after 5 years, it will be yearly once of a follow. So now, what are the modern technologies that we use for treatment purpose? We call it as image-guided radiotherapy and or adaptive radiotherapy. These are the terms that are coming up in the future. So adaptive radiotherapy is nothing but there are two ways that you can do this. This is the one is the online adaptive radiotherapy and offline adaptive radiotherapy. The one we use is the offline adaptive radiotherapy, where, for example, if the patient has head and neck cancers, and the patient we have started the patient on a treatment, and after 3 or 4 weeks, what we see tremendous skin, the fat loss. So what happens is there will be definitely a change in the volume. So now we need to change. We need to redo the CT scan. The CT scan is done again, and the planning is done again. This is called as adaptive radiotherapy, and which we so this is done with the guidance of image guided radiotherapy. So we do take images during radiation therapy to see if we are treating we are accurately treating the lesion, And this image guided radiotherapy plays a very important role for certain types of cancer where the respiratory movement is more, and so the motion will be a lot. For example, if it is going to be a stomach region, or even liver, so where we actually see a lot of respiratory movements. So when there is a lot of respiratory movement, what happens is the margin that we have given can be it will be difficult. So this is where this image guided becomes very useful. So the image guided radiotherapy again is used in stereotactic radiotherapy. What is stereotactic body radiation therapy? This is called as SBRT, and this is coming up a big way in the future, because even in a setting where you have limited metastasis, SBRT plays a very important role there. Because SBRT, what we try to do is we give a high dose per fraction, but this is for only few days. It will be usually 5 sessions, mostly it will be 5 to 7. So unlike the conventional where we give it for 5 weeks of treatment, here it is more dose, and for number of days is also less. So this has to be more precise. So so what helps here is the image guidance. So what image guidance we use a cone beam CT scan, or we use MBCT. So such kinds of image guidance is used. This will actually help us not to miss the target. And because in SBRT, we generally recommend SBRT for small tumors. We don't do it if the tumor is large. If it is going to be a large size tumor, conventional radiation therapy for number of days also increases. That is preferred over the number of fractions like SBRT. So smaller tumors we recommend SBRT. And also, if it is metastasis, and it is not a widespread metastasis, it is not diffuse everywhere, it is a limited metastasis, and the size is also very small, we do give stereotactic body radiation therapy there. So do we are very precise and very careful when it is going to be SPRT, because we'll be using immobilization devices also here. Because we don't want the patient to move during the treatment procedure. So immobilization devices, like mask, it's very simple. We just have a thermoplastic mask which will be placed on the patient's body and which site we are going to treat. So that helps us because the patient will not be able to move, and we tell them what we are going to do, the process. And once the beam is on, actually, if you actually see the radiation therapy treatment, once a patient is on the couch, it takes about at least 20 minutes to finish, or 20 maximum 20 minutes. This is because it takes time for us to set up the patient, and also for positioning using the immobilization devices. This is why it takes actually when the beam is on, and actual treatment will take only like 10 minutes or 15 minutes maximum. It depends on the technique that we use. Otherwise, it is going to be only 20 to 30 minutes of treatment because of the setup. And sometimes we will have protocols like bladder protocol. For example, in prostate cancer, we use something called as bladder protocol, where we ask the patient to drink certain amount of water and wait for um, few minutes. It can be 15 to 20 minutes. It depends on the institution. We do that. This is be done so that we don't want the bladder to receive more dose when the prostate is receiving radiation therapy, as well as it also helps to push the bowel up from the field of radiation therapy. So it is pushing it away from the radiation therapy field. So this way it actually helps. So now, again, talking about SBRT. So SBRT is done in sites like lung, liver, pancreas. We do SBRTs, and also if there is any metastatic deposit, that is, if the disease is from the primary organ, it has spread, and that disease is there in the bone, we can also plan for SBRTs. So now, can we do such kind of treatment in the brain? Yes, we can do. It is called as stereotactic radiotherapy. The stereotactic radiotherapy will be done from, it will be either three fractions or five fractions. It depends on the size of the tumor. Sometimes we can also plan for just a single fraction of radiotherapy. This is in the, I'm talking about the brain. And remember, for CNS tumors, we also have conditions other than the malignancies where we can actually use radiation therapy for benign conditions. So benign is generally opposite of malignancy, right? So certain benign conditions like cavernoma, glomus tumor. So such conditions, we do use a radiation therapy as a modality of treatment for local control. um, for a local control, we do use radiation therapy, and even schwannomas, certain conditions where the surgeon might feel it difficult to remove the tumor. In such scenarios, we do use a radiation therapy as a modality to give to achieve local control. So SRTs is generally done in the brain. So this requires more precise planning, and we again use the immobilization device here. We have a brain mask for the patient so that the patient doesn't move. This can be depending on the size of the tumor. So 1 day is done, or it can be 3 to 5 days of treatment. And we keep the patient on follow up again. Once the treatment is done, we keep the patient on follow up. So now we're coming to radiation therapy as a palliative means. Palliative means it has a well established role for many years. Pain palliative radiotherapy is used as a modality for pain control, and also in situations, emergency situations like brain metastasis. If the patient has an increased intracranial pressure, so the patient will present with lot of headache, vomiting. We do give whole brain radiotherapy if it is a proven metastasis, radiological proven metastasis. And then again, there are certain scenarios where emergency radiation is planned. For example, spinal cord compression. So where disease is present in the bone, and also it is trying to touch or impinge the cord which is nearby. In that scenario, what we do is we actually get a surgical opinion, surgical opinion, spine surgeon or opinion, and if there is no surgical intervention, we will give them radiation therapy as an emergency basis. This is to prevent cord compression. So again, there is another scenario where we also use radiation therapy. This is in a bleeding scenario where there is a lot of bleeding from the tumor as such. You call this as hemostatic radiation therapy. We give higher dose per day. We give higher dose per day to actually cut off the so this immediately arrests the bleeding. This is used mostly in head and neck tumors where there can be a big ulcer in the neck and which is bleeding profusely. So here sometimes hemostatic RT helps. Moving on to the foot pipe, we are moving towards an era of precise oncology. So now the treatment modality for foot pipe, that is esophagus, is more towards including trying to include immunotherapy as part of the treatment regimen, even in a definitive setting. So esophagus also we do have a role. Esophagus and stomach we do have a role. And in esophagus is a well established role prior to surgery. We give radiation therapy along with chemotherapy, and this actually helps in getting better results. In the pathological response rate is also very good when you try to do a radiation therapy prior to the esophagus. Okay. And benign conditions. Talking about benign conditions, there are few benign conditions where we get the help of radiation therapy. For example, keloids. Keloids is a very thick scar that you see. Generally, what we do is we try to give injections for the scar. This is done by the dermatologist, and if it doesn't settle down, We try to excise it with the help of the plastic surgeon here, and then within 24 to 48 hours we give the in radiation therapy, and we have very good local control rates, because keloid has a tendency to come back again. So we try to give the radiation in 3 to 5 days, and we get good results with radiation therapy. This is one example where in benign conditions we do give radiation therapy. And again, in like I said, schwannoma is again a benign condition where we give radiation therapy. And also in eye condition, we call it as Graves ophthalmopathy. We give the dose that is used for malignancy is not used in benign conditions. But here, what is the role of radiation therapy in benign conditions? Actually, what happens is radiation therapy can also act like an anti-inflammatory, like how the paracetamol acts. So because it also has an anti-inflammatory action, just similar to that, an analgesic, an anti-inflammatory action is exerted by the radiation therapy in benign conditions.